tympanic part because it's next to the.
What is the definition of the labyrinthine part?
Yeah, I'm not sure.
So if you see this, you are absolutely right that this is the facial nerve canal, but facial nerve has got various parts around the temporal bone or around the medullary cavity. And my idea of learning temporal bone is around nerve. So if you know your facial nerve, around that knowledge, you build your concepts. This is the tympanic portion of the facial nerve. If you see here, this is the medullary cavity. This is the epitympanum. This is the malleus. This is the incus. This part is here. Now, what is this part? What is this? Candidate one?
Yes, if that's the tympanic part, so
No.
is this
So
one?
tympanic part is this one. There is something else which is just superior to this level. Of course, on an axial slice, you are seeing a bit of partial voluming here. So my question is, this tympanic, let me ask you in different, direct words. The tympanic portion of facial nerve passes underneath this structure. This is a hint. And
okay,
what
that's the semicircular canal, but it's the lateral one, the lateral semicircular canal.
Excellent, excellent, well done. Okay. Now, these are the two owls, eyes of the owl, right? Just like your case, cholesteatoma case, which you saw. This is the medial, this is the lateral. What is this? What is this? Over to you. This is the same question which I asked in that, your cholesteatoma case.
Yeah, so then that has to be the facial nerve.
So name the parts. Hint is,
yes, the parts that I need to name.
So this part one here is the same part which you saw here.
Okay, the tympanic. Okay.
So this is the tympanic part. What is this part?
Is that then the labyrinthine part?
Excellent. So that is the labyrinthine. So we'll come back to this. This is the labyrinthine portion, and this is the tympanic portion. Okay, so let's go back. Now, overview of the skull. Now, this bone, this red bone, of course, these are various bones of the skull. We are interested in the temporal bone. Now, the temporal bone has got 5 different portions, technically speaking. This part is the squamous temporal bone, squamous part of temporal bone. It forms part of the middle cranial, floor of the middle cranial fossa. What is this? This groove, candidate one?
The groove for the middle meningeal artery.
Excellent. So this is the middle meningeal artery. And interestingly, out of the bones of the skull, squamous temporal bone is the thinnest portion. And this is very dangerous because if somebody gets a trauma here, there can be an epidural hematoma because of middle meningeal artery rupture. Now, on the other hand, another part of temporal bone is this, the petrous part of temporal bone, which is our main area of interest. And this is the densest bone in the human body, remember. So coming back, I was telling you that there are 5 parts of temporal bone. Squamous part, mastoid part, tympanic part, styloid, and the petrous part. So out of these parts, we are most interested today in the petrous part of the temporal bone. Now, from here, let's go to the concept of base of skull. Now, base of skull, by the way, is going to be our curriculum next time. But you have to have an overall concept. So without going into details, let's see the base of skull, beautifully seen on this diagram. Base of skull is made up of 5 bones. Out of these 5 bones, 3 are single bones. These are midline single bones, and 2 are paired bones. Paired bones include the frontal bone and the temporal bone. Now, the midline single bones include the ethmoid, and then the sphenoid, and then the occipital bone. Now, the sphenoid bone has got various parts. First is basi-sphenoid, and we are interested there because this is the portion which touches the petrous apex, and there is a synchondrosis there. So the basi-sphenoid is part of the sphenoid bone, which is midline, and all of your pituitary fossa, you know, the sella, the anterior clinoid processes, the posterior clinoid processes, the sphenoid sinus, etc., is within this part of the sphenoid bone. We'll cover it next time. This is the lesser wing of sphenoid, and this is the greater wing of sphenoid. Again, we'll cover it next time. We are more interested here. So here in the midline, the basi-sphenoid forms a joint here at the clivus, and there is a joint here also. And so part of the clivus is made up of sphenoid bone, and part of it is made up of the occipital bone. So these are, you know, the occipital bone has got various parts, which include, you know, other than the clivus, the condylar process and squamous part, etc. We are not interested in detail. Now, if you see here, the petrous temporal bone forms a synchondrosis, and in this synchondrosis, it is joining the occipital bone, and it is joining the sphenoid bone. So there is a joint here. This foramen here is known as foramen lacerum, and foramen lacerum, by the way, in a live person, you know, it is filled up of cartilage, etc. The carotid artery, internal carotid artery passes superior to that. So it passes here, and here is the cavernous sinus. It is hidden within this petrous temporal bone in the carotid canal. It passes like this, and then it goes here into the cavernous sinus. So coming back to the petrous temporal bone. Now you have to concentrate what I am, so this is our main subject today. Now the petrous temporal bone is pyramidal shape. So there is an anterior border, there is a posterior border, and there is an inferior, should I say anterior surface, posterior surface, and interior surface. There are various foramen. And one of the foramen is this one. This is the internal auditory canal. In the internal auditory canal, the 7th and 8th nerve, they will pass through it. But there are so many other things which are passing through the petrous temporal bone. We have just covered that the internal carotid artery passes through it, through a canal, which call it the carotid canal. And then the facial nerve has to pass into the parotid gland through it. So there is a stylomastoid foramen also. Now, candidate 1, what is this foramen?
That one below the lacerum.
So lacerum was here.
Yes, lacerum.
And nothing of interest passes through, as I was telling you. In a cadaver, it looks like this. Otherwise, there, you know, for us, there is nothing important passes through it. What is this? And this is very, very important. Hint.
This is the jugular foramen.
Excellent. So key concept is, please remember, and it's an anatomy question, and it is a true and false type of, you know, the question will be that the jugular foramen is a foramen in the occipital bone, and the answer is false. And another MCQ, jugular foramen is a foramen in the temporal bone, and again the answer is false. Please remember, it is a foramen in between the two bones. So this is the occipital bone, and this is the temporal bone. And this is a hugely important, anatomical landmark for radiologists, jugular foramen. Jugular foramen, even here, you can see that it has got two portions. This one is known as pars nervosa, and this is known as pars vascularis. You don't have to learn this, but it's a good idea because you will not then get confused when you see it on a CT scan. The contents which pass through the jugular foramen, as the name tells you, is internal jugular vein. But with that, there are three nerves: ninth nerve, 10th nerve, and 11th nerve. Now, the name here is pars nervosa, telling you as if nerves are passing through it. Having said that, only ninth nerve passes through it. 10 and 11, they pass with the internal jugular vein in this pars vascularis. So you don't have to remember it, but it's a good idea to see that, this will be the sort of a shape, and we will cover it on a CT scan. So this is the jugular foramen. Now, this thing here, if you see, is known as arcuate eminence. This is a thick part which makes the superior most portion. It is superior to the superior semicircular canal. So these were, let's take it further. Now, if you see here, this is your clivus. As I was telling you, that clivus is made up of two bones. One is the occipital bone, and this is the basisphenoid or the sphenoid bone. In a growing skeleton, there will be a synchondrosis there. There will be a joint, and this shows on a CT scan. So don't get confused. If you are doing an on-call report and of a trauma, child, don't get confused that this is a fracture line. And on an MR, don't get confused. So this is the basisphenoid. This is the basi-occipit, which is part of the occipital bone, and this is known as the spheno-occipital synchondrosis. And in an adult, it will become just one bone. Now, look at these nerves, and these nerves is a repetition. And part of today's talk is repetition, 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 and this is what I told you in the beginning. So if you see here, this is the occipital bone, and this is the petrous temporal bone. This is the internal auditory canal, where the 7th and 8th nerves are going into the temporal bone. This is the jugular foramen, and this is the 9th nerve. This is 10th and 11th nerve. And look at the shape. So this is the pars nervosa. This is the pars vascularis. So on this side, it is clearly seen. This is how the jugular foramen will look like. Now, another thing is that at this level, at the level of pons, there are other nerves which are coming out. So two nerves are going into the temporal bone. These are the 7th and 8th nerves. But anteriorly, there is a 6th nerve. Look here. It's a skin nerve. So you can see it on an MR, but you have to look at it carefully. Now, this nerve passes through the sphenoid portion, this basisphenoid, and then it goes into the cavernous sinus. And I'll show you a case, which is an exam case, petrous epicitis, where there is inflammation or infection at the petrous apex. And it can cause, you can see the anatomy here, that this is the region. It can affect this nerve, which is the 6th nerve. 6th nerve passes into the cavernous sinus, and then it supplies the lateral, this muscle, extraocular muscle, lateral rectus. So the patient will present with palsy of this lateral rectus. Of course, in the cavernous sinus, other nerves are also passing through, and it will cause involvement of those nerves also. Same thing, if there is infection here, can cause other things like, cavernous sinus thrombosis. So this anatomy is the key. So we'll see it as the last case of the day later today. Now, this is the 6th nerve, and slightly more superiorly, the fifth nerve is going anteriorly. This is the trigeminal nerve. It is a big, thick nerve, and we can see it very well on a CIS MRI scan. It goes into this part, which is known as Meckel's cave, very well seen on an MR, and it divides into three branches. V1, which is the ophthalmic branch, and then the maxillary branch, V2 and V3. V1 and V2, remember, they go into the cavernous sinus. V3 is favorite in the exam because it goes through the foramen ovale and goes into the masticator space. And I'm going to show you a case today of perineural spread. So this is the anatomy. So I repeat, fifth nerve, which goes into the Meckel's cave, two branches, V1 and V2 goes into the cavernous sinus. V3 goes through the foramen ovale into the masticator space. Now, sixth nerve passes through the sphenoid bone and goes into the cavernous sinus, and of course goes into the orbital. Seventh and eighth nerves, they go into the internal auditory canal. And ninth, 10th, and 11th, they go into the jugular foramen. 12th nerve, this is hypoglossal canal, we'll cover it next time. So these are the nerves of interest today. And just to make a point, repetition, that these are the nerves which pass through the cavernous sinus. Of course, oculomotor and the third nerve, third and fourth, we did not mention because they come out at the midbrain level. Then, of course, the V1 and V2 and V6. Sorry, not V6, the sixth nerve, should I say. Now, just concentrate on what happens with the carotid artery. Now, carotid artery is coming through the neck. It is the content of the carotid space. It goes into the petrous temporal bone, the pyramid. And if you see here, it travels through it vertically, and we will see it on a CT scan now shortly. You can see this, it is going vertically. This is known as vertical portion. And then there is a horizontal portion in the carotid canal. And then it passes, look at this, it passes it passes on top of the foramen lacerum. And then it goes into the cavernous sinus. So you remember that this is where it is passing through the cavernous sinus. Okay, so candidate 1, anatomy question. What is this? Which foramen is this? Candidate 1?
Sorry, yes, sorry, I was trying to unmute myself. That's the jugular foramen.
And what is this?
And that's the anterior to jugular is that's the carotid canal.
Excellent, well done.
Yes, medial, continues medially as well.
Yeah, so this is the carotid canal and this is the jugular foramen. And now, same thing here, next slice, you can see here, this was the vertical portion and then it has turned into the horizontal portion, and the jugular foramen is still visible here. Now, candidate 1, what is this? What is this? It's a bit harsh because there is a bit of partial voluming, but there is a canal here. So what is this?
It's not continuation still of the carotid canal, no?
Yeah. So this is the carotid canal, and this carotid canal is the horizontal portion of the carotid canal. Now, what is this where my arrow is? What is this?
This is the apex of the
excellent. So this is the petrous apex.
Petrous apex, yeah.
Now, petrous apex, please remember, in various people can have various kind of appearance because it can be pneumotized. So if you see here, these are mastoid air cells which has got air inside. So these can be also in our patient, there are no air cells, but in many patients you will see that there are air cells and you should not be confused about it. So let me show you a DICOM, CTA and CTV, and the aim is just to show you, just one second. Can you see my DICOM viewer?
Yes, I can.
Okay, so let's go through this anatomy once again. Now, this is, let me put in a sagittal there instead of a coronal. Now, our aim is, let me change the window here to bone window. Now, our aim is just to see the vessels through the carotid canal. Now, can you see my mouse, candidate one?
Yes, I can.
Okay, so if you see here, this is the common carotid artery. Now we are going up in the neck, and it divides into external carotid and the internal carotid. Now we are going to follow the internal carotid and see how it goes into the carotid canal. So this is the internal carotid. Let me trace it backwards. So this is the internal carotid artery. And we are, even here, if you see here, this is the carotid artery and this is the jugular vein. And everything here is together is in the carotid space. And now this carotid artery, internal carotid artery, goes superiorly and it is touching the base of skull. And here, this is the vertical portion where you see this thing, you can see it as a cross section, because this is the vertical portion as we had described of the carotid canal. Now you will see it will become horizontal. Now it has become horizontal. It is passing through the petrous part. Here, you know, it is passing superior to the level of the foramen lacerum. And here, it is going into the cavernous portion, cavernous sinus. And of course, then there is supraclinoid portion. That's not part of our mandate today. We are just interested in the carotid canal. Now, let's see the jugular foramen. So I am now, if you see here, I am going superiorly. So you can see that this is the superior sagittal sinus. And so this is the superior sagittal sinus. And we are coming inferiorly. This is the superior sagittal sinus. And then it divides into the transverse sinus. Now it goes here. This is the sigmoid notch. And then it passes down. And now it has to come out. So it will come out through the jugular foramen. And it then passes into the neck. And here, this is the carotid space where we can see it. One point to remember here is that when we will cover carotid temporal bone or the middle ear, the middle ear cavity, just remember that jugular foramen or is inferior to the level of the middle ear cavity. So it indirectly forms the floor. But there are normal variants in which it will be at a slightly higher level. If you see here, you can see that this is the head of the malleus and incus, and this is the internal auditory canal. So I am going inferiorly, and now you don't see it. And then you see the jugular foramen. Key point to remember that it makes the floor, but as a normal variant, at times it can be what we call high riding jugular foramen. Now, on the other hand, the carotid artery is anterior to the medullary cavity. So these 2 points are important for you to remember. So this is the medullary cavity, and the carotid canal is anterior. There are normal variants in which this bone will be dehiscent and the internal carotid artery can project into the medullary cavity. Similarly, in high riding jugular foramen, the internal jugular vein can project into the medullary cavity. We call it high riding dehiscent uh, jugular foramen. But these are normal variants. Otherwise, normally, key point to remember, jugular foramen will be the floor and the carotid canal will be the anterior wall of the medullary cavity. Okay, what we will do is that we will take a 5-minute break and we will rejoin after 5 minutes. So after the break, it will be candidate 2. Thank you, candidate 1. Now, if you see here, this is the facial nerve. It's a schematic diagram, but it tells you everything. This is the pons, and this is the facial nerve. It comes out. This portion of the facial nerve passes through the CP system, the cerebropontine angle system. Then it passes into the internal auditory canal and then into the temporal bone. This portion where I'm pointing out is the labyrinthine portion of the facial nerve. It passes anteriorly, and this thickening is known as the geniculate ganglion. So this is the geniculate ganglion. And from here, it turns on itself and passes posteriorly. This is the tympanic portion. And this is also known as the anterior genu. And as it passes through, this is somewhere here is the posterior genu, and then it passes vertically down. This is known as the mastoid portion. So I repeat, this is the labyrinthine portion, the geniculate ganglion or the anterior genu, the tympanic portion, and then the mastoid portion or the descending portion. You can imagine that the parotid gland will be sitting here. It will pass into the parotid gland, and then it will divide into terminal branches. One branch of interest goes anteriorly from the geniculate ganglion, and this is the greater superficial petrosal nerve. It supplies the the lacrimation, so it controls the lacrimation, and it also supplies the sublingual and submandibular glands. So on this axial, now this axial is key for you because all of this anatomy can be seen on partly CT scan and partly MR. So this is an axial slice where it comes out. So this is the facial nerve. It comes out, and so it passes through the CP angle, then goes into the internal auditory canal, and then it passes superior to the cochlea. So the cochlea, of course, is inferior to it. It passes on top of it. This is the labyrinthine portion. This is the lateral geniculate ganglion, or the geniculate ganglion. And then this is the tympanic portion. Now the tympanic portion will pass inferior to the lateral semicircular canal, and then it will descend down, the descending portion. And here the greater superficial petrosal nerve is shown to be going anteriorly. Now here you can imagine that it rises at a higher level than the eighth nerve. So it is superior to the cochlea. On the other hand, this is the cochlea, and the cochlear nerve comes out of the cochlea. This is the vestibule. Vestibule has got various components, including saccule and utricle. You don't have to remember intricate details for FRCR, but you should know that there are semicircular canals. This is the superior semicircular canal. This is the lateral semicircular canal. This is the posterior semicircular canal. This is the endolymphatic duct and the sac. Now, this is a potential exam scenario where, because we can see it on an MR, and we can see it on a sagittal sequence of MR. Within the lateralmost part of the internal auditory canal, actually there are 4 nerves. And as I was telling you, they can be seen on an MR, and this has been asked in the examination. There are 4 nerves. Anterior superior quadrant is the facial nerve, common sense, because it is at a higher level. So this is facial nerve. Anterior inferior quadrant is the cochlear nerve. It comes out from the cochlea. Sorry. And Then there is superior and inferior vestibular nerve. These will join together. So candidate 2, name this nerve. You can't unmute. Okay, let me help you.
Yeah, so that's the facial nerves.
Right. Which is this nerve? So candidate, okay, what we can do is, candidate 1, you are already a co-host as far as I am concerned. And I think there is a technicality. Try it again.
Yes, so now it's possible.
Okay, so what is this nerve?
That's the 8th nerve.
Which nerve? Name the name.
Vestibulocochlear nerve.
No, my question is, you see, this is the lateral most portion, and you are seeing 4 nerves. Which one is this?
Vestibular nerve.
This is the inferior vestibular nerve. That is the answer. If you see here, this is the superior vestibular nerve. This is the inferior vestibular nerve. The formula here is 7 up, which is the 7th, and coke down. So this is the cochlear. Superior vestibular, inferior vestibular. So these 4 will be seen on a cis-sagittal sequence, and this has been shown in the exam just like this. This is a coronal, sagittal oblique type of a sequence. 7th nerve, cochlear nerve, superior vestibular, inferior vestibular. What happens is that they join together to form the vestibular nerve, and then they join the cochlear nerve to form the vestibulocochlear nerve. So this is posterior because this is cerebellum posteriorly. Now, so just a repetition of what we have already learned. This is the labyrinthine portion, geniculate ganglion, greater superficial petrosal nerve, tympanic portion, and the descending or mastoid portion. And you can see how it goes into the parotid gland and then gives the terminal branches. Now, we have learned one branch coming out here. There are other nerves. One of the nerves is this nerve. There is a muscle here, which is known as stapedius muscle within the middle ear cavity. And this joins the stapes. It causes what we call sound damping. And there is a nerve which provides, there is a branch which provides innervation to this. This is the nerve to the stapedius. There is another nerve here, which is known as cauda tympani, which actually on a CT scan, you can see it on a sagittal sequence. It comes out and passes through. Cauda tympani supplies, what is the candidate to? Cauda tympani. What do you know about it?
So it's the tongue.
Yeah, good.
Posterior 2/3 of the tongue.
Anterior
It supplies,
2/3.
sir, it supplies anterior 2/3 of the tongue.
There is a confusion. There are 2 candidate 2s who are speaking. So, Azhar, if you are listening, can you sort that out? Who is candidate 2? Because there are 2 candidates 2 who are speaking. Now, so this is cauda tympani, and this is part of the function of the facial nerve, anterior 2/3. So from here, what we can learn? We can learn that there are various functions of the facial nerve. Clinically speaking, we can see.
Sir, it supplies. Sir, the chorda tympani nerve supplies anterior two-thirds of the tongue taste receptor.
Madam, there is, excuse me, there, I think there is a lag or something because I was not asking you. Can you mute yourself? Because right now we are in another, I'm asking the question to another candidate, and I believe there is a confusion. Two people have sort of registered as candidate twos on the system. Okay, Azhar, if you can text them and sort this out, who is candidate 2 and who is candidate 3 or 4. Now, this is chorda tympani, and so various functions of the facial nerve include lacrimation, which is controlled from here, sound dampening, which is controlled from here, anterior two-thirds of the taste, and then there is what we call muscles of facial expressions, which are controlled from the distalmost branches. Okay, now we go from here. One of the main parts of anatomy where we are going to learn on this one. If you see here, candidate 2, can you hear me?
Yes, sir.
Okay. So here, part of the exercise is that we are going to develop our concept about the facial nerve. So what I do is when I am reporting a temporal bone, to orient myself, I see the cochlea. So I call the cochlea the flower. This is the flower. It is a very prominent structure. And of course, cochlea will be at the level of the cochlear nerve. So here will be the internal auditory canal. Now, as I'm going superior to the level of the cochlea, so once again I go inferior. Which we are doing right now is to trace the facial nerve. This is the cochlea. I'm going superior to that. And you can see that there is a canal here, and this is the labyrinthine portion. And it goes here, and this must be the geniculate ganglion. And then you can see that something goes posteriorly. This is the tympanic portion. It is going posteriorly. Just concentrate on this, where my mouse is. This is now we are going posteriorly, and it is now going to descend down. So it is descending down, and I am going inferiorly where the arrow is, and ultimately it goes into the stylomastoid foramen and then goes into the parotid. You can imagine that the parotid gland must be sitting here. So this is, let's track it once again, the facial nerve. So this is the cochlea. We go superior to the level of the cochlea, and we can see that nerve is coming from the internal auditory canal, going anteriorly, and then the tympanic portion goes posteriorly, and then it becomes a ring because we are seeing it end on. It is descending down, and ultimately it goes out. Let's see a few landmarks surrounding it, but we will not overwhelm ourselves. Cochlea, of course, is a landmark. We go superiorly. Now, here is the lateral semicircular canal. And on this side is the medullary cavity, the head of the malleus and the incus. This is what we call epitympanum. And you can see this hourglass appearance. This is known as editus ad antrum. This is the epitympanum. This is known as editus ad antrum. And this is the mastoid antrum. And these are the mastoidal cells. So coming back to landmark is this lateral semicircular canal. And the tympanic portion, it passes inferior to that. We will see it very well on a coronal section. Now we are going inferiorly. So here, if you see it very carefully, you can see a triangular structure where I am pointing out. This is known as, actually you can see it here very well, where I'm pointing out. You see this? And this is known as pyramidal eminence. We will learn about it subsequently. If you see it very carefully, there is a dot here. So this is the stapedius muscle actually. And this thing is the descending portion, and it will go out. Another point to remember is that, okay, so what we do is that we go to the coronal section. So, and again, first of all, let's orient ourselves. So, if you see here, this is the internal auditory canal. Now, this is a good point to, it's a very, very powerful landmark here, that this is the lateral semicircular canal, this is the superior semicircular canal, this is the internal auditory canal. Now, I am going posteriorly, and you can see that this is the cochlea. So here are two dots, and these are the dots which I showed you initially. So let's trace it backwards. This is the internal auditory canal, and you can see something entering here. So this is the dot which is superior to the cochlea. This is the labyrinthine portion of the facial nerve. And now it goes anteriorly, and here it becomes one. You see, these are two dots. I go anteriorly and it becomes one. Why? Because this is the geniculate ganglion. And from the geniculate ganglion, I am going backwards once again, and you can see the two dots. This is the tympanic portion of the facial nerve. It will pass below the lateral semicircular canal. And here it is. And you can see that this is lateral semicircular canal, and this is the facial nerve. This section is a very important, this cut for your exam, because if you see, this is the lateral semicircular canal, and there is bone here, and this is air here. In cholesteatomas, what can happen? A cholesteatoma will be sitting here. It will erode this portion, and then there we will call it fistulization of the lateral semicircular canal. And fistulization of lateral semicircular canal can cause a lot of symptoms, and they show it in the exam. You have to learn how to diagnose it on an axial and also on a coronal. Now this is the tympanic portion, and we will see we are going posteriorly, and we are expecting it to dip down vertically. And you, on a coronal, you will see it very well. You see this thing? It goes vertically down like this. And you can imagine that this is the stylomastoid foramen, and here will be the parotid gland. Now, if you see the relationships, here is the epitympanum, this is the sputum, this is the external auditory canal. So now let's go for a sagittal. Sagittal will show you the descending portion very well. So otherwise, there is not much value to the sagittal. So these are the mastoid hair cells, and you can see, here you are. We call it the hockey stick appearance. This is the descending portion. This is the stylomastoid foramen. Many a times you can actually, if you see carefully, this, you see this thing. This is the chorda tympani. It is slightly off center. So here you are. You see this thing. This is the chorda tympani. Then it will pass through the middle ear cavity and supply the what we call ultimately anterior 2/3 of the tongue. We will come back to this. So right now, our aim was just to develop our eyes on the facial nerve. So Okay, candidate 2, can you see my diagram? This is external ear and middle ear.
Yes.
Okay, now with this background, we have to develop, and there will be repetitions as I was telling you. Now, if you see here, this is the external auditory canal. It has got a cartilaginous component and it has got a tympanic, a bony component. This is the tympanic membrane. Superiorly, tympanic membrane is attached to this part, which is known as sputum, and inferiorly to the tympanic annulus. This sputum is an exam thing. I showed candidate 1 this thing. This part here, where I am pointing out, this air here is known as Prozac space. And there are 2 types of cholesteatomas. One of them is known as sparse placida cholesteatoma, which is the most common site. The cholesteatomas occur at this site, and they cause erosion of this sputum. So that is one of the key things to remember. Now, coming back to this anatomy, this is the tympanic membrane, this is the inner ear, and this is the middle ear. Now we have to concentrate on the middle ear. But look at the surrounding structures. This is the internal auditory canal, and the nerves are coming in. This is the lateral semicircular canal, the superior semicircular canal, the vestibule, and part of the cochlea. Now look at it. These are the ossicles, the malleus, the incus, and the stapes. Now look here, same thing, but a bit of a close-up here. Now this is malleus, incus, and then this is stapes. This part is known as epitympanum. This is known as mesotympanum. This is known as hypotympanum. Now, if you see superiorly, this is the roof, which is known as tegmen tympani. Tegmen tympani. Now, various portions of the ossicles. So, these are the ossicles. This portion, you don't have to remember everything. You just have to remember that the malleus is attached to the tympanic membrane. But the head of the malleus is here. It is in the epitympanum. Head of the malleus is an exam thing because they will show you cases of incudomalleolar dislocation. So this will be a head trauma case in which there will be an incidental finding of a fracture of the temporal bone and maybe incudomalleolar dislocation. I'll show you. So this is the head of the malleus. It joins the body of the incus. Then there is a short process of incus and there is a long process. And this long process then joins to the stapes. The stapes has got anterior crus and a posterior crus. This is the foot plate which joins the oval window. Now, if you see here, a repetition, this is the stapes, and the capability of CT scan now is that, stapes is the smallest bone in the human body. Anterior crus is 0.58 millimeter, posterior crus is 0.6 millimeter, and we can actually see it on a CT scan. And we can see actually the joint also. So, with this background, this is a key diagram. Now you have to really concentrate, and part of it is going to be repetition. And this is the main diagram on which you have to concentrate. Now, you are sitting in this. This is the middle ear cavity. On this side is the external ear. On this side is the internal ear. Now, there are various walls. So this is the lateral wall. This is the medial wall. Posteriorly is the posterior wall. We are looking through the anterior wall. Just remember that anteriorly, the structure which you should remember is the carotid canal. So carotid canal is anteriorly. Now inferiorly will be the jugular foramen. Superiorly is the tegmen tympani, and then the brain. You see this thing? So this is tegment tympani, brain there. Inferiorly, jugular foramen. Lateral, external ear. Medial is the internal ear. Posteriorly, we are going to learn, because posterior will be the mastoid. And anteriorly, remember that the jugular correction, the carotid canal will be there. Now, concentrate on the medial wall. The medial wall is critical. Now, our friend is the facial nerve. Okay, before I go to the facial nerve, one thing which I want you to concentrate on is you divide the middle ear cavity into 3 stories. So this is the attic, and this is the, the main room, and then is the basement. How do you divide it? Now, this is the tympanic membrane. If you draw a line, imaginary line, from here to the tympanic portion of the facial nerve, here, superior to that, and the lateral semicircular canal will also be at times at the same level. Superior to that will be the epitympanum. This is the mesotympanum, also known as the middle ear cavity proper. And this is known as hypotympanum. Hypotympanum is nothing. It is just empty, just a trough in the floor, nothing more than that. So don't worry about it. Just remember that below the hypotympanum will be the jugular foramen. Now, so this is mesotympanum, epitympanum, and hypotympanum, which is not important. Now, this is the facial nerve canal. Now, this is passing backwards, and this is the lateral semicircular canal. Here, what is happening, that this is the cochlea, and there is a bulge here, which is known as cochlear promontory. Coming back to the ossicles, if you see, this is the handle of the malleus, but the head is sitting here. So the head is in the epitympanum, and the handle is in the mesotympanum. Here, it joins the body of the incus. And there is a short process and there is a long process. Now, long process tips down once again into the mesotympanum. And here it makes this joint with the stapes, which is joined with the oval window. If you see here, now concentrate on the posterior wall. So we are looking at the posterior wall. There is a hole here. This hole is the additus ad antrum. And on the other side of the hole will be the mastoid antrum. Slightly more inferiorly, the landmarks on the posterior wall include this thing. This is known as pyramidal eminence. And this pyramidal eminence can be seen on axial CT scan. Remember, the descending facial nerve will be next to it. This portion here, which is medial to the pyramidal eminence, is known as sinus tympani. And I will show you on a CT scan. So this is the main, concept to remember. Now, once again, we are looking at the medial wall. So this is the promontory. This is the facial nerve canal. This is the lateral semicircular canal. And from here, a bit about the internal ear. So I'm not at all going to go into the details of internal ear, which is beyond our curriculum. But please remember that internal ear has got an exoskeleton, which is bony. We call it the bony labyrinth. And inside is fluid containing structure, which is known as membranous labyrinth. Some of the names are common. So for example, cochlea and vestibule. So there will be a bony labyrinth or an exoskeleton and an internal skeleton which has got fluid. So the fluid will be well seen on MR and the bony component will be well seen on CT scan. So this is cochlea. which has got 2.5 turns. You don't have to go into details. This is the vestibule, which has got utricle and saccule. Don't go into details. Then there is lateral semicircular canal, superior semicircular canal, posterior semicircular canal. You have to remember them, particularly the lateral and the superior. Then there are endolymphatic duct, which is this one, an endolymphatic sac, and there is a cochlear aqueduct also, and a perilymphatic duct. Don't worry about that. So this is a diagram, shows you the microscopic structure of the cochlea and the nerve going in. So this is the flower we are talking about, few MR sections. Now, if you see here, this is the lateral semicircular canal, and this is the flower, which is the cochlea. So, and you can see the nerves here going, the cochlear nerve and the vestibular nerve, as we already know. This is the coronal section where you can see the superior semicircular canal, the lateral semicircular canal, and the vestibule. So this is the cochlea, and this is that sagittal sequence, which is an exam sequence, as I have told you. Now, with this background, we are going to conclude the anatomy by seeing a cis IAM and then a dicom of the temporal bone. And we will repeat a few things, and this will consolidate everything. So let's go for a cis axial sequence of the IAM. So candidate 2, can you see the cis sequence?
Yes, sir.
Okay, so if you see here, this is a bit of a repetition, nothing much. I'm sure you will, you already know it. This is that flower. And from the flower, which is the cochlea, you can see this nerve going here. If you trace it backwards, it joins these nerves. And on an axial sequence, you cannot make out what is what. You know, the superior vestibular and the inferior, where I'm pointing out. Superior and inferior vestibular, which one is what? But they join together and they make a thicker nerve here, and then it goes into the pons. So this is the vestibulocochlear nerve, which divides into cochlear component and two vestibular, superior and inferior vestibular nerves. Other than that, you can see that this is the vestibule, and this is the lateral semicircular canal. You see, it will make a circle like this. And something which makes a circle superiorly, so this is making a circle superiorly, will be the superior semicircular canal, and this one is posterior semicircular canal. Let's go to our friend, the facial nerve. And you can see there is a thinner nerve than this one here. And this thing goes. And you can see that the cochlea, this is the cochlea, it is going superior. So the cochlea is no more visible, which makes sense. And then you lose it. And you can see on a CT scan, it is still visible, but on a MR, you don't see it. This is a cis sequence. Now, let's see the fifth nerve and the sixth nerve. So these are the two Meckel scale. This is pons, and you can see the fifth nerve going in. You can imagine that it is going into the Meckel scale here. And of course, the V3 will go down into the foramen ovale, and the V2 and V1 will go into the cavernous sinus. Now, if you look very carefully on this, we might be able to see the sixth nerve. Now, sixth nerve has to go anteriorly from the pons. So, if you see here, for example, this thing where I'm pointing out, it goes here. So this is the sixth nerve, which is passing into the sphenoid bone there. Okay, now the final repetition on a DICOM, and then we will see a few viva cases. Candidate 2, can you see a DICOM viewer?
Yes.
Okay, so now what we are going to do, we will slightly make it larger and just concentrate on left side. So if you see here, when you are seeing the temporal bone, my landmark was cochlea. So this is the cochlea. But let's have a more global view now. So if we go back, this is the clivus, and then we have got, this is the internal auditory canal. So this is the cochlea. And as I'm going superiorly, this is, okay, let me make it bigger. This is the labyrinthine portion of the facial nerve. It goes anteriorly and then it descends posteriorly. And it is, so this is the lateral semicircular canal. It is going posteriorly and now it is going to descend down. So we are at the posterior wall. And ultimately it will go out. So we trace it backwards. Now, this is a landmark on the posterior wall of the mesotympanum, where you can see this pyramidal eminence where I'm pointing out. And it will be next to the sputum, which is visible here. This is the descending facial nerve. This portion where I'm pointing out is known as sinus tympani. And sometimes this is a clinical blind spot, because when the surgeon is coming from here, they will not see this thing. And there might be a cholesteatoma sitting there, which we have to point out. So this is the posterior wall. Now, coming back to rest of the middle ear, this is the epitympanum, and this space here is the prozac space. Head of malleus, body of incus. So this space is the prozac space. This hourglass appearance is the additus ad antrum, and this is the mastoid antrum. And if we go inferiorly, we go into the mastoid ear cells. On the other hand, on the axial slice, so we can see that this lateral semicircular canal is projecting here. As we go inferiorly, so I'm going into the level of the mesotympanum. And here you can see the pyramidal eminence has come into play. You can see the scutum correction, the stapes here. And you can see the tympanic membrane here. You can see the external auditory canal. And as I go further inferiorly, I am going to go into other structures. So I'm going inferiorly. And here, one area of interest is inferiorly. This is the jugular foramen. So let's see it on once again on this sagittal sequence. And we can see that this is the lateral semicircular canal, and this was the sputum, So superior to the sputum, this is the epitympanum. From here till here is the mesotympanum. Hypotympanum is not important. This bulge here is made of by the cochlea, which is this thing, cochlea. The facial nerve is coming from here. This is the dot, which is the labyrinthine portion, the geniculate ganglion, and then the tympanic portion, which passes underneath the lateral semicircular canal. And this is the descending portion. So, now, other surrounding structures, if you see here, this is the carotid canal. So this is the horizontal portion. If we trace it anteriorly, it will go into the cavernous sinus, which is sitting somewhere here. We are going posteriorly. Now, this is it. And then this is the vertical portion. On the other hand, this is the jugular foramen. So this is the anatomy. And now let's start a bit of viva cases. Oh, just 1 second. Candidate 2, can you see my blue slide?
Yes.
Okay, now this is open for chat. So this is a final repetition. I think I've got 4 slides here. It's a quiz. And this is for you to, everybody can participate. This is open for chat. And I'm going to ask one by one. So, answer number 1, what is this? Good. Number 2. Yeah. Okay. I'll give you the answers in the next slide. Number 3, what is this? Number 3. Excellent. Then number 4. If you see here, just to highlight that this structure is partly aerated. And look at this side. You remember the one which I showed you before did not have air cells. So this is pneumotization. Okay. Number 5, what is this? And then number 6, what is this? So I think all of you got it right, but the answers are in front of your eyes and everything is perfect. Okay, now, sorry, what has happened? So number 1, please. Good. Number 2. Excellent. Number 3. Excellent. Number 4. Number 5. Number 6. Number 7. Number 8. Okay, so there were a few different answers for number 8. And so this, if you see carefully, this is the tympanic membrane. So this is the middle ear cavity. We are just able to see it. Now, now, if you see here, this mandibular condyle should be part of your protocol when you see a CT of the head trauma. And many a times it has come in the exam, they will show you an axial CT and mandible condyle is not sitting in this fossa. So there will be dislocation. On an axial CT, very easy to miss. So this should be part of your protocol. Okay. Number one, please. Number one. Number two. Number three. Okay. Number four. Number five. Pyramid. Okay. Let's go through them. I think this is a bit harsh for the simple reason, steppies, for the simple reason that I can understand you don't, it is not projecting very well for you, steppies, and the arrow is slightly off. So it's a bit harsh. So I think I'll disregard that. The point was that the steppies is visible here. And this flower, of course, is cochlea. This thing is the vestibule. Now, this answer, I think there is a typo here. This mastoid air cell should not be here. This is facial nerve. Mastoid, it is the descending. And if somebody has said that there is a pyramid here, so that is fine. But my main point was this black dot, which is the descending. So this is a typo. So disregard that. Apologies for that. Now, last, number one. Number two. Number three. Number four. Number five. So number five is regarding this bone here. And number six is this black space, the air. The space between this incus and the bone. And number seven is this this structure. This, which is projecting here. Yeah, this is a bit harsh because there is a bit of partial volume. So this is, this is the tympanic portion and there is a partial voluming. This is the lateral semicircular canal. But I do accept that this is a bit harsh. Prozac space out of the malleus and part of the cochlea. If you have mentioned the turn, it is fine. This is the internal ear. This is the vestibule. Right. So on a coronal, this one. What is number one? And number two? Labyrinthine facial nerve. And number three? Tympanic facial nerve. And this one is the bone, and this is that space, this black space. Excellent. So these are the answers. All of you got it right. So, I have Sorry, I think I've already shown you the answers. Let's do it in any case. So number 1, number 2, 3, 4, 5. So this is the vestibule, the superior semicircular canal, the lateral semicircular canal, the tympanic portion of the facial nerve. A bit of repetition here. So I think this is easy, where we have got the vestibule, the superior semicircular canal, the lateral semicircular canal, and the tympanic portion of the facial nerve. Okay, last section, coronal. Number 1, number 2, these are harsh because you just see them partially, but you can imagine something going superiorly, you can imagine something going laterally. And then you can see that something is going inferiorly. And then this thing here, number 4. Yeah, very good. So these are excellent. A sagittal sequence. So what is number 1? Good. And what is number 4? Number 4, please. Excellent. So that is the stylomastoid foramen and facial nerve. Okay, so this was the case when we started. So this is the scutum which is eroded. There is soft tissue opacification which is involving the epitympanum as well as the mesotympanum. This is the tympanic portion of the facial nerve. This is the labyrinthine. Nothing is happening there. On this slice, we don't see the lateral semicircular canal, but we can commit that the tegmen tympani is not eroded. So this ossicle maybe looks slightly attenuated, maybe slightly attenuated. So this was just to develop anatomy. Now we will take 5-minute break, and then we will see few in the last hour. We are going to see viva cases of the temporal bone. Candidate 2, you are with us?
Yes, sir.
Okay. So now we are going to see a few viva cases in the last 1 hour. First thing is cholesteatoma. Now, let me tell you a few theoretical points about cholesteatoma before we see the cases. Basically, what is happening in a cholesteatoma that so this is from Chapman. Cholesteatomas, of course, can be congenital and they can be acquired. We are talking about acquired cholesteatoma here. And the classical location includes pars flaccida, which is 80%, pars pensa is 20%. Candidate 2, you can see my slide, Chapman's slide.
Yes, sir.
Okay. Now, you have to remember the pathology, what is happening. Basically, in cholesteatoma, you see here that because of otitis media, there is retraction membrane and the skin cells, they go into the medullary cavity. And you remember that one of the properties of the skin cells is exfoliation. So they keep growing and they have got keratin inside. That becomes a ball and that ball keeps growing. And this keratin has got some properties of absorbing the bone. It takes years and years to develop, but gradually it will destroy the structures. Key finding on a CT scan are two. One is that non-dependent opacity with bony destruction. Where and how the bony destruction will be, we will see. But how good are we on a CT scan to diagnose cholesteatoma? Our sensitivity and specificity is not very good, which is obvious. But these are the two key points which we remember. And you see, this is the concept, focal accumulation of exfoliated keratin within stratified squamous epithelium. CT scan, you know, this will not enhance either on CT scan or on MR. Surrounding granulation tissue can enhance. Key point to remember is that cholesteatoma can cause on MR, it will show restricted diffusion. This is key point to remember. Actually, you remember in CNS, we have done epidermoids. Now, histologically speaking, epidermoid is the same thing as cholesteatoma. The only thing is that when it is within the intracranial cavity, we call it an epidermoid, which is when it is in the scalarium, we call it an epidermoid. But in the temporal bone, we call it a cholesteatoma. We have made life, uneasy for ourselves, difficult for ourselves. But remember that it will show restricted diffusion. So with that background, if you see this picture here, what is happening? This is a classical cholesteatoma, which is at the Prozac space. This is cholesteatoma. So if you are an ENT specialist and you are doing horoscopy here, you will actually see it. An early white type of appearance. And many a times the clinicians, they tell us that I can see a cholesteatoma, please see what is happening inside. Tell me the roadmap, what to do when I'm going in, what to expect. So this is a classical pars flaccida cholesteatoma. And gradually it will erode this scutum. This is in the Prozac space. And it will erode this ossicle. But then there can be pars tensa cholesteatomas also. It can be in other parts of the medullary cavity. They can be very large. Look at this example where it has eaten up everything. And look at this tegment tympani, which is eroded. Lateral semicircular canal is eroded. It can erode the facial nerve canal. ossicles are eaten up. So all of these things can happen. So if you see here, pars flaccida, pars mensa cholesteatoma. The main thing to remember is non-opacity with non-dependent opacity with bony destruction. Now look here, candidate 1. If I tell you that this is a cholesteatoma, can you prove me right? Sorry, candidate 2. Can you describe it? What's happening?
There is a soft tissue attenuating lesion in the middle ear cavity abutting the malleus and incus. There is no erosion of the adjacent bone. This is in the dependent portion, so and there's no erosion, so it's unlikely to be a cholesteatoma.
If you see here, it's vice versa actually. The dependent portion is this one.